Is Caries Detector Dye BS? Like, I know lots of dentists who've seen it and they think this is just a fad. This is as useful as those photos of people holding cucumbers between their teeth. Is there actually any science or useful applications? Because caries, as some colleagues would say, I just use my high magnification, my good lighting, and my probe. I don't need a fancy dye to tell me if I've got caries or not. I'm experienced enough to know that I've removed caries. Now, you know what? I kind of felt that way. I was like, do I really need a dye? I think I'm pretty good at removing caries. And to be fair, since I've been using it, it's kind of confirmed that I'm pretty good at removing caries. Okay, I'm happy to say that. I'm proud enough to say that. However, 1 in 6 times, I see a pink haze where it shouldn't be. And you'll find out what that pink haze means in this episode, but it's really useful objective data. So we'll speak to Dr. Germán Dorgan all about Caries Detector Dye, how to actually use it properly, what is the evidence base behind it, and how to interpret the data that you get by using it. Hello, Protrusive, I'm Zaz Galati, and welcome back to the Protrusive Dental Podcast. If you're new to the podcast, welcome. It's great to have you. Every main episode, I do a protrusive dental pearl. Some good tip, often clinical, sometimes non-clinical, that's going to help you in practice tomorrow. The one I have for you today is very much linked to the theme of this episode, i.e. how not to expose, how to remove the appropriate amount of caries to get the best bond strengths possible without risking removing too much dentine and causing a pulp exposure. So how do you do that? You use some landmarks. Use your perio probe and some landmarks. And the zone that should be ultra clean, the zone where you should be aggressive in caries removal, if that's a fair enough term to use, is if you measure from the cusp tip down 5 millimeters. In that zone, you're not going to hit the pulp. So please remove the caries. And from the adjacent tooth, so let's say you're doing a first molar, you can measure from the second molar, the marginal ridge of the second molar, 3 millimeters into the first molar distal. Then that is your zone that you should keep super clean. And in those ranges, in those 5 millimeters from the cusp tip and 3 millimeters from the adjacent marginal ridge, you're not going to risk exposing. And so therefore you should try to get this really lovely clean peripheral zone. But you'll hear more about that in the main episode with Germán. So next time if you're wondering, should I remove some more? Should I not? Will I expose? Maybe you can use a perio probe. Just be sure to warn your nurse first, because the first time you ever do this, you ask for a perio probe out of nowhere, randomly in the middle of caries removal, you're about to expose, and your nurse be like, wait, why are we now suddenly doing a BPE or something, right? So make sure you maybe tell your nurse what you're doing first. We'll go ahead and join the main podcast now. This episode is suitable for 50 minutes of CPD. It's via the Protrusive app. If you're not on the app already, do download it. It's on iOS and Android, even on the web. You can just go to protrusive.app as a website, and that will load the app as a web app, so you can access it there as well. And for premium members, you can answer a few questions at the end and get your CPD, as well as a transcript in PDF, and the premium notes that you see on the side will be given to you as a PDF. I'll catch you in the outro. Germán Dorgan, welcome to the Protrusive Dental Podcast, my friend. How are you?
Very well, thank you, Jess. Very excited and ready to go.
Mate, you are, I know you're buzzing. We had a little chat earlier about you're still buzzing from that World Cup win. I can sense the energy. I was enjoying your social media sort of banter about you and how Argentina was doing. I was happy. I won £150, you know. I had Argentina as one of my teams in the sweepstakes. So I won, and so I treated my practice to pizza. So I threw everyone a pizza party. So everyone was happy that Argentina won.
That's really fair. I only won 8 heart attacks in the final, so.
No, that was an epic final. I don't think we'll ever see a final like that again. So that's amazing. But Germán, you're very active on social media. We've been connected for a few years now. What I see you do in terms of your passion for biometric dentistry is amazing. And you got me hooked to Caries Detection Dye. I love this stuff. Absolutely love it. When I first got the bottle, I was like, I have no idea how to use this, read the instructions. And now when I use it, I'm like, wow, I was missing so much of it. And I guess we'll talk about my experiences and your experiences with it. But for those of you who don't know you, who don't yet follow you, tell us a little about yourself, your journey when you came over to UK from Argentina. Was that after qualifying or?
No, so I was born in Argentina, but I was raised in Spain. At the age of 5, my parents moved to Spain, to Madrid, and that's where I grew up. And then I've got grandfather dentist, mom dentist, father dentist, sister dentist. So I had to follow the steps of everybody. So graduated in 2010 in Madrid. After a couple of years of 2010 was a very, very hard time in terms of economical crisis, and I wasn't very happy working in Spain, so I decided to just move to the UK. I actually came for a couple of years to try to make some money and improve my parents' practice, but that was 2012, and I'm still here. Start working on the NHS, and then after a few years, as I was learning, I was finding a few struggles, unfortunately, in terms of use of certain materials and providing certain treatments to my patients. That all started after doing Paul Tipton training. Luckily, I managed to increase my private work to provide this to most of my patients, and I focus in restorative and adhesive dentistry with a big background of biomimetics. 2019, I got into Matt Najat's course when he came to London. That hooked me into Element's mastership over a year. Then I had the opportunity to train with Emulate, but also help them teaching a little bit. And currently, I'm taking part of Get Bonded and Step Bonded with Sami Sharif. Great course.
I mean, now you're teaching with these guys, right? You're an educator with them, which is amazing, man. Well done.
Yeah, that's a great step. We're doing a good job. We're actually bringing David Alleman in March for a session, a couple of days of biomimetics, and then taking also part of the Mimetica it's a 1 year program. It's a European program with 3 huge guides, in my opinion: Philip Kulemans, Hugh Barn, and one of my greatest friends and probably mentors, Raphael Wyman, which are helping me to understand adhesive dentistry, like what Alleman will call get bonded and stay bonded, if that makes sense.
Amazing. And from, speaking to Taylor Patton on the previous episode, it is really, get bonded, stay bonded is such a great way to summarize the field of biometric dentistry. And part of achieving those great bond strengths is actually your caries management, your caries removal, because if you're going to bond to caries, it ain't going to stick. You're going to be disappointed. And that's where we spoke on social media. You recommended Caries Detector Dye. I asked you about it and you told me which one to get. So let's start with that. What is caries detection dye? It looks pretty on social media, but is it BS? Is it any good? I know you have a bias, but the bias is led by literature and it's led by some time of you using it and your mentors using it. So just start from the very basics. What actually is it?
So yeah, it's a very good point what you said. You cannot bond if your foundation is not good. Okay, so imagine building a house and the base is really soft. The house is gonna crumble down. So we really have to find a way to see what we have underneath. And Caries Detector Dye is a disclosing agent, red fuchsin, on a glycol solution. The main purpose is to stain denaturalized collagen, okay? And this is a very important point because it's not staining bacteria, okay? We're not looking for bacteria, we're looking for denaturalized collagen, okay? We know that the bond strength...
So to make it clear, Germán, it is not a plaque indicator. It's completely different from plaque indicator.
Correct, exactly. So we know that if we have denaturalized collagen, the quality and the bond strength of that dentin is not going to be as good as if we have sound dentin. So the Caries Detector Dye basically aids on the excavation of the outer decalcified and infecting dentin, okay? And that basically allows us to have an optimal caries removal, okay? So if we have a good caries removal, we are going to achieve good seal, and more important, prevent issues like losing pulp vitality. So it could be a problem because if we're not sealing the caries properly, it will keep going down and eventually we're going to end up with an irreversible pulpitis or further problems.
Yeah, some people who are not very open-minded, and me as a practitioner, I'd never been taught about the use of caries detection dye. I'd only ever seen other people using it, and I'm quite an open-minded clinician. I'm happy to try new things as long as it's got a scientific rationale behind it, which obviously as caries detection dye does. I was very open to using it, and I love it. But the same thoughts that go into my mind go into other people's mind, but I still give it a go. I still want to give things a go. Other people are like, well, I have my probe. I've been using my probe for years. I can feel the dentine. I know that this is soft and this is hard. Why do I need some color to tell me that? Now, obviously, I've been using it, so I can answer that, but you're in a better place to answer that. What do you think?
Yeah, okay, so we're talking about how to be objective and subjective in this matter. Okay, so it's perfect. That's a good way to do the description. If we can see what we're treating and we can identify the substrate by different colors, we're going to be able to know what's there. However, let's say you use the probe. The first point I will have is like, how can you measure every millimeter square of the surface of the cavity that you're doing? Good luck with that. You know, I'm not saying that you're not wrong by trusting, and I think it's part of the clinical judgment that you're going to have. You have to feel what you're treating, and that will be part of the guidance. But I think it's not completely accurate, and I believe that you will get surprised that if you finish a caries removal just with your burr and testing with a probe, eventually, if you try with a drop of Caries Detector Dye, things will change and they will blow your mind somehow, showing that you probably left tissues there that are not going to provide appropriate bonding and proper seal of the surface. And especially when we're talking nowadays that the contemporary concepts are saying that we can leave caries behind as long as we seal it properly to starve the bacteria and then kill it. Okay, so if you're having a leak, that's not going to work, and then it's going to bite you back eventually. I think another point is like how subjective is hard for me. How is like, I think I explained this with in a talk with Ash. Is a very, very simple thing. You and me go to the gym, but I believe that I go only twice a month, but you go every day. Okay,
I wish.
Okay, yeah. Well, I'm putting just an example, but 10 kilos for you, if you're going every day, it's not going to be heavy. 10 kilos for me, that I go twice a month, might be super heavy. So we really cannot have always, all of us, the same feeling.
Tactile feedback, and it's the same as perioprobing, Germán. Perioprobing, you're supposed to use 25 grams, I believe, of weight when you're doing perioprobing. But when you actually get the tests, the algometers, whatever they use, everyone's actually usually a little bit too much, but everyone's different, and to achieve that optimum is difficult.
How do you screw an implant? What do you use? A torque wrench?
I don't. I use a referral pad.
Okay, fair enough. No, but it's a good way to think it. No, but if you think about it, when we're doing implants, for example, if we need to know how much torque we have to give to a screw, we need something to measure it, and that's why we use a torque wrench, for example. Okay, and if we want to be even more accurate, we're going to use probably a digital one. Okay, so I think having, especially when the main thing that we're doing as general dentists is remove caries every day, we should have a systematic or a way that we can really kind of standardize the way that we're removing caries to achieve proper results. You know, and I think it's an important thing. And I don't believe the tactile
feedback
is not accurate, and there are papers from Fusayama that even more important when we're getting closer to the pulp, the closer that we're getting, okay, acute and chronic decay, there is no difference in the elasticity and the hardness of that surface. So if we're dealing with deep cavities and we want to prevent pulp exposure, your best way to address it will be helping yourself with something to visualize what you're removing and having a little bit of knowledge of the anatomy of the tooth.
Well, we'll talk about that in terms of, okay, once you do use the Caries Detector Dye, how to interpret that data. But I think, yeah, it's a good first point that the data is good because it turns something subjective. You know, one of the first things I learned was the color is unreliable. You know, we used to chase everything until it was yellow. We then know that, okay, it's okay to leave brown and black based on amalgam staining, etc. And so that was fine. Yeah, I think people still struggle to believe that your probe and the softness, even that can fool you because that is subjective data. And I completely agree. So to give you my experience of using Caries Detection Dye so far in the last 6 months, I'm usually, now I'm using it, it's validating, it's giving me peace of mind. Okay, yeah, this is what I expected. I thought this was caries free, and my Caries Detector Dye is confirming that. However, the odd time, 1 in 6 times I've done it, as like, oh wow, I've actually missed a bit there, and I should go back. And it made me feel really good. And it also gives me a zone that I know that, okay, this zone, we'll talk about these zones, I can be a little bit more aggressive here, I can leave a little bit more behind here, and it gives that nice zone, which I know we'll get into. So I'm so far very much converted. I'm a big fan of it, and the odd time it has surprised me. I thought, thank goodness I've got this as objective data. So I totally agree that more people should use it. When should you use it? Should you use it do you use it for every restoration, every caries restoration, or is it only for the deep ones?
Everything. First of all, not disrespecting anyone, but if I'm replacing any restoration, I need to find out why. Okay, so let's say there's a recurrent caries and we're removing a filling. The first thing I want to check if, okay, it could be C factor, it could be something that poor bonding protocol, not enough light cure, something has happened. But the first thing I'm going to probably try to check, and this is where I respect how open-minded you are, because as soon as you heard that, it was like, okay, I'm going to try it, I'm going to give it a go. And you clearly notice the difference. When I started my biomimetics and most of my adhesive restorative dentistry, it was because things were not going well in many of my treatments. So I had that curiosity to find out why. So I'm replacing a filling. Let's say a patient is coming with some sort of sensitivity, there is a fill-in. The first thing I'm going to do is an investigation. And the first step is, as soon as I remove my fill-in, check with the Caries Detector Dye. And we'll say that in very, very, very high percentage of those cases, I'm finding affected dentin or even infected dentin in areas that shouldn't be. So what we're basically saying here is there are areas that are not bonding properly. So therefore, that restoration is starting to fail, causing problems to the patient.
So that is, just to make it really clear for someone who might have missed what you said there, this is as soon as you remove the restoration, you haven't even now started to remove any caries yet, because I guess the point you're trying to prove is, why did it fail? And if you use it straight after removing a restoration, you can see that there is still caries near the sort of external margin and was leaking.
Correct, exactly. So it could be probably the thickness of the cars, it could be the C factor, but definitely I want to check if there is appropriate caries removal. Okay, so because I'm taking over this treatment, so I need to sleep well, like you said, and I need to make sure that I'm going to achieve high bone strength and therefore longer prognosis of my restoration. Whenever I'm going to do any caries, even if it's like something that is a deep caries, definitely it will help me to prevent pulp exposure, because I will have knowledge of my landmarks and I will know where I have to stop. But more important, how to create that famous peripheral seal zone that helps to seal the bacteria and preventing them from going deeper. And in those cases, what I will probably do is as soon as I remove kind of like the dirty area, we will call it like that, and I'm starting to have my cavity, so I know that I'm starting to go a little bit deep, then is when I'm going to start using my first few drops. And I'm saying drops because it's not one drop. Okay, most of the people will say, oh yeah, I do one first drop clean, but they don't check. So we will talk probably when we go into how to use it.
Let's just talk about that now. What is how much you use? So I can tell you what I've been doing, and I'm happy to say it live on air if you like. I might be doing it wrong, and feel free to tell me. Is at the moment, and I didn't read the instructions in terms of the way it's delivered. I know it's supposed to leave it for 10 seconds, and that's why I remember, and that's why I do before I wash it away. But I have it in a dapping spot, and I've got maybe like 2, 3, 4 drops in there, and I'm mixing my microbrush inside there, and then I'm rubbing my microbrush into the cavity. Am I doing it wrong? Am I doing it right?
No, absolutely perfect. I used maybe a couple of drops in the brush, and that's more than enough, or in the dapping. But what I'm doing is constantly trying. So I clean and I try. I clean and I try. I always test it. Because one thing is a staining.
So you're talking about reapplication. So you're applying it, waiting 10 seconds, you're washing it away, then you're reapplying it.
I clean my surface, okay, and then I will test myself if I clean it properly, okay? Because it doesn't have enough penetration sometimes, so we really have to do reapplications. in the different steps that we're going through the removal of the caries.
Got it. Okay. But in terms of the actual procedure of how I'm applying with a microbrush and just rubbing it all the way around,
it's just
that's
one.
okay, right?
Yeah.
Leave it for 10 seconds, wash it away. Perfect. Fine. So before we talk about how to interpret that data, which I think is so key, and we'll talk about the peripheral zone and using your landmarks, what does the evidence say? Is there much evidence in terms of how reliable the data is, that this objective data that you're getting from the color, from the Caries Detector Dye, how reliable is it?
This has been studied since 70s, 80s, okay? And the most important thing, and especially I think this is something that for me, it clicks a lot in a way of we're measuring affected dentin. So we know the bacteria is going through, there is acid attack, and that's producing the denaturalization of the collagen, which is what creates the good and the bad bond on the surface of the tooth. And studies are from late 70s, 80s, and they are showing that even without complete removal, so leaving infected and affected caries, we're getting high bond strength. Well, high bond strength. If we're talking about infected dentin, we're getting around 10, 15. But if we're leaving affected dentin, we're around 20s, okay? So 25. If we think about bonding to enamel, we're getting 31. Okay, so even not complete removal is showing us that it's high bond strength. Okay, and then if we actually have sound dentin, we're achieving up to 50s. How do you achieve it is a different thing, and I think it's what you spoke with my previous colleague about how to bond to dentin and more the principle of biomimetics, and it's all about a matter of time, allowing the bond to mature properly in order to achieve high bond strength. Okay, so obviously there is several papers that are showing that we're able to bond to caries, and how effective is the fact that we can visualize what we're bonding. How do you describe infected or affected dentin without having anything that is showing you? You know, I cannot, it doesn't go into my mind. It's like infected dentin. We know that by discoloration, we cannot differentiate the different surfaces. So it has to be something. And in this case, it's the Caries Detector Dye what helps you.
When you are seeing the different colors, like let's say you've got a large cavity, you remove the caries to what you think should be removed. So you've gone by your usual subjective data, and now you're gonna rub in the Caries Detector Dye. Then you wash it away after 10 seconds, and you see what's left behind. Does the color gradient, does the pink versus red tell you something? Is it assuming you're using a red one? Obviously, you use a green one, it's different, but let's go with the red because that's the one I have.
So yeah, if you have a look to the first papers that are coming around the 80s, what they're saying is that the infected dentin stains, whereas the uninfected dentin or affected dentin doesn't stain. Okay, that acid attack on the affected dentin has been more aggressive. Okay, so everything has collapsed, and it allows the dye to penetrate. That's why it will get darker. It's not that.
Wait, on the infected dentine, it's been a more attacked, right? Yeah.
Exactly. Whereas the affected, the denaturization is not so aggressive. So let's think about the progression of the decay. There is acid at the front. Yeah, that acid attack hasn't been so strong. Okay, that dentin still has the ability to remineralize, which is the important thing why we can preserve it and why we have a higher bond strength. Okay, so if we're trying to penetrate with the Caries Detector Dye, it's not going to be so easy. So that is when you're going to get a lighter pink. Okay, so the red will be the affected dentin, completely unremineralizable. Okay,
no, the red is the infected,
and the pink is the affected.
So the pink is affected, and then obviously if you get no staining at all, that's obviously completely healthy, and that's fine. And you
sound
go
dentin.
With that.
Yeah.
Well, let's give us some guidelines now in terms of if you have some pink, when is it okay to leave the pink, and what position in the cavity is it okay to leave the pink? I think that's important as well. So we'll come to the red in terms of when you're getting near the pulp and stuff, but let's start with the pink. If I see some pink, which is the affected dentine, but it's near the ADJ, it's near the DEJ, then that's affected dentine. Now we can bond to affected dentine better than infected dentine, but is it safe to leave it at the ADJ?
So that will be basically losing a 30 to 50% bond strength. Yes, because we said we're going to go around 20s, 25, 30. Okay. if I'm not going to expose pulp, why will I leave it? I want to increase my bond strength for a more successful restoration. So therefore, it's basically, the idea will be to leave it around 2 millimeters inside of the DEJ of sound dentin. Okay, so there shouldn't be any pink haze near the DEJ.
Perfect. And then when we get closer to the pulp, at what point can you leave red?
Okay, so the red. This is a bit of, if we go to that paper that Pascal and David Alleman released in 2012, there are some landmarks that is letting us. I will share you the little pictures with the probe. I think having a perio probe is quite important to prevent pulp exposure. Okay, so what it's telling us is to avoid pulp exposure, we have to measure 5 millimeters from the cusp tip and 3 millimeters from the adjacent marginal ridge to create that peripheral seal zone. Okay, so if you see that picture, we will have like a tooth. So from the cusp, we're going to measure 5 millimeters from the tip and then 3 millimeters for the marginal ridge of the adjacent teeth. Okay, if we are not having adjacent tooth, which can happen, we have to think about the curvature of the tooth. So obviously, if we're high up, those 3 millimeters that you're measuring, predicting that there is a tooth next door, it will be different because the amount of dentin will vary. What I will have is those 2 millimeters of clear dentin. But we have to use the clinical judgment, okay? We have to look at the x-rays. An older patient will have more retracted pulps, so we will be able to be a little bit more aggressive, okay? So these are standard measures that we're gonna use, but we also have to use x-rays. Otherwise, and that's the important part, you're gonna leave a lot of red that, again, doesn't bond properly. So the reason why it bonds is because it managed to get into the affected dentin, but in the middle, you're not going to get such and the loading fatigue will have an impact or even fail and allow the progression of the caries again.
So in order not to expose the pulp, we want to make sure that we have no color, no pink, no red in the peripheral zone of at least 2 millimeters all the way around. But if you've got a particularly deep cavity and you're worried about pulp exposure and you get your measurements 5 millimeters from the cusp tip, 3 millimeters from the proximal marginal ridge, and it is more acceptable to leave your pink and red in that zone. Is that a fair summary?
Exactly. And then obviously, this is just something what I have is my abrasion unit. So we know to increase bond strength, it's a great tool. Okay, so paper shows that.
The literature's quite mixed, right? There's some literature that says that abrasion doesn't increase the bond strength, some that says it does, some that says it doesn't. Maybe it's because of the plaque biofilm removal effect. What's your stance? You're more well read up on this than I am.
At the moment, most of the things that I read are going towards using air abrasion to increase the bond strength, and that's how you achieve a 50 megapascals on bond strength and in sound dentin. Okay, so if you read papers from Bambervik.
Yeah. Are you anal about like some dentists like it has to be 27 microns on the dentine and 50 microns on when you're doing indirect work? Like it's not practical sometimes. So is it a sin to use 50 microns on dentine?
So that's dentistry, and there's so many papers and everybody tests differently, and that's the problem we're having. We're all testing differently. So in terms of, for me, if it's something outside the mouth and I'm talking to zirconia, which I barely use it's not a material that it's a common thing that I use because of the low bond strength, I will use 50 microns outside the mouth. In terms of the mouth, I'll stick to 25, and the reason is because it really doesn't show any significant difference between one and the other. And what I will say, if you go quite handy, quite heavy on your hands on a 50 microns, you're probably going to remove much more than what you want. And this is exactly what I was going to try to say. Sometimes when I get to my last stage, I've done my measurements and I do a nice thorough air abrasion to remove that kind of red that is there. And if pops quite a big amount and I end up with a pulp exposure, it's very likely that my bacteria was already in the pulp. Therefore, that pulp exposure, I will take it as like it was going to be needed. I was going to end up or either doing pulp capping or I was going to end up doing a root canal treatment because the pulp was affected by bacteria. Bacteria was inside of the pulp. Okay, so I will go with 27 microns on that last part area, gently but enough to just like clean and see all that part of like soft decay coming out, if we can call it soft, if that makes sense. But is that red area?
Well, for those who listen to the pulpotomy episode by Surezan, they'll be saying pulpotomy, pulpotomy, pulpotomy. But that's a different episode. You guys should listen to that one. That was a really good one. Here's an interesting one. Not interesting. It's just something that's annoyed me, and I was really looking forward to this chat to speak to you about this. Is when I use the Caries Detector Dye, and obviously the pink and the red that's in the middle. Is it okay just to leave it? Because now that I've done my washing, I've done my aeroblation, there's still a little bit of pink and red there. And I was thinking for the longest time, like, oh my God, how do I get rid of this stuff? Is it okay that it's there? Please tell me you can bond to it.
Oh, of course. That's what I said to you. And if you see the articles I send you, those two, Yoshiyama and Nakajima, that's the name of them, they do the studies bonding to caries-affected and caries-infected dentin using Caries Detector Dye. And they are getting those numbers of 25, 30. Will it decrease? Maybe, maybe not. We don't know. But how do we know if we're testing that or not? And it's still getting a 25 or a 30, on enamel is 30. So we're getting on that pink haze a good number. If by that 10, 15 that I'm getting in caries infected, basically avoiding pulp exposure, I'm winning. I'm already winning. I'm preventing a root canal treatment. And most important, you now have the ability, because the pulp is still alive, to heal. So if there is any inflammation, it's likely to heal. But obviously, we're all different. Yeah. Not everybody has the same immune system somehow.
Of course. So, but just to clarify, you're not using anything to actually remove the pink or the red once you, which is. I was just thinking about that. What was I supposed to do?
Remember what I said? The last thing I do, I test myself by another application, another drop of Caries Detector Dye, and then I rinse it, and then I check if I have a proper periosteal.
Okay.
Because it's very often done that they clean, and on the last clean, they don't check it. So they just go to proceed. But if you check that, sometimes you might get surprised that you actually left affected or infected caries in areas that are not, affected dentin in areas that shouldn't be.
Sure. I'm using the Curare Caries Detector Dye at the moment, the red one. I like it. I think next time when I finish this bottle, I'm going to go for green, because in case there is a pulp exposure in the future, I worry that if I've got something pinkish red and I might not notice.
Do not. When you see the pulp exposure is evident how the little bit of blood comes out. Many times I'm able to see how come the pulp horns are starting to show off. So that is actually, remember what I said, clinical judgment. It's not only about my Caries Detector Dye, it's a few things that are coming together to find that caries removal endpoint, okay? So you will see that red coming out. It's not often that I find the patient, it's hurting, I do everything, and someone just did a pulp exposure 10 years ago. You can see the hole and it's all dry, okay? So you can see the pulp horn was exposed, and that is visible. And green or red, the most important thing that you have to have is the content of glycol, okay? The glycol content is the only thing, because it's what helps you to penetrate. And I don't know exactly the brand. Basically, Curare will have around a 90%, but there is one of the brands, I can't remember, I'll try to send it to you, that basically the percentage is around a 45%. So is it actually penetrating? No. So it will tell you that you probably clean, but you haven't. So as long as you have a high percentage of glycol to allow the fuchsin to penetrate properly, to allow the dye to go through.
Curare, awesome. I'm a huge Panavia fan, so when I saw that Curare did that Caries Detector Dye, I was like, I trust Curare, so I gave my money to them. But if you find out the name of this Mickey Mouse Caries Detector Dye, you let me know, and I'll make sure that no one ever buys that.
I'll find it. I think it's half a puff or something like that. I think Ultradent is also good content of glycol, is another option that you can have, and I think that one is green if you want, but I haven't seen it. I only have used Curare since I started, and one bottle of them will last me very long time. It's a lot of Caries Detector Dye. So
for someone like you who's using it very heavily, it does last a long time. So you answered all the questions I had. Germán, tell us now, anything that you think we've missed, that you think it's important to know before someone, for the naysayers, for the haters, for those who are still not convinced that, you know what, this is just BS and I'm still going to rely on my probe because I'm old school or whatever. Anything you want to say to those guys, or anything you want to say to those who are going to now maybe try using Caries Detector Dye and they're interpreting the data for the first time? Anything that you think we haven't covered yet?
Yeah, I think the most important thing is that, and I have chat this with you so many times, we have to do what we do know best. Okay, so introducing new things, they will have a learning curve. They take time, and the best thing that you can really do is learning and have someone that can mentor you or help you on the process. Okay, using Caries Detector Dye or not, it's a personal choice. I'm not going to force anyone to do it. We don't have to force people to do protocols that they don't feel comfortable, because the only thing that you're going to create is hate. And dentistry is science, not a dogma. Okay, so that's the important thing. Important really is to share those cases with people that are probably knowledgeable in the matter. Either I know Instagram can be a hit and miss, but there are lots of great gurus. That's how I met you. That's how I got in contact with you, and I learned a lot of TMJ thanks to you. So obviously we have to have a little bit of discretion on the matter, but absolutely share those cases, ask questions, be active. You will not learn. And second thing, you will notice that when you're using Caries Detector Dye, you will be a little bit more aggressive than if you were not using it. So many times what I find with the students is that because they are not cleaning it properly or they're not removing enough, they're really leaving some substrate that is not bonding as good as they could bond, just because they are scared of having a pulp exposure. So, and this is where sharing those cases with other people will help you and will basically make you improve in using this Caries Detector Dye. And there is an important article that talks about Caries Detector Dye is too aggressive. And what they were testing actually was that they were leaving pink haze close to the DEJ, but they weren't finding bacteria. Are we testing bacteria?
No, because you said it's not a plaque indicator. Exactly, yeah.
Exactly. So it will become a little bit aggressive, and that's the myth. And there is a big myth in Caries Detector Dye being aggressive. And there is a restorative book that was used very, very frequently that was saying the Caries Detector Dye was not good because it was too aggressive. I was removing too much tissue, but it was because the test, once again, was done based on a different data or something that we shouldn't be testing. So it was a mistake, and that person didn't understood what we're testing with Caries Detector Dye, and they tried to find bacteria and they didn't find it. But we are trying to achieve high bond strength by having good dentin or
to get the
high
best
bondable
substrate
dentin.
possible. Yeah, yeah.
Exactly.
I mean, it reminds me, Herman, of something my mum says, and she says it in Punjabi. It's a Punjabi saying, but it basically translates to the truth is always bitter. So sometimes when you use the Caries Detector Dye, the truth is revealed. There's no hiding from it. And what you see is that, oops, I have been leaving a bit of caries affected dentine in that peripheral zone where I should have been removing it all this time to get the best bond strengths at that, first couple of millimeters of dentine. So super important. So Herman, thanks for covering this episode. You got some exciting stuff coming with the Alaman's coming, and it's at the cricket ground. I'm so gutted I couldn't come because I'm on another course. Typical. Tell us about that, my friend. That's super exciting.
So we are 3rd and 4th of March, David Alleman. We're going to spend either 2 or 3 days. It depends on what's going to be planned. Is David and Davey Alleman both come in with Sammy and me helping. So we're going to be at Lord's in the cricket ground, London. So we're going to review all biomimetic restorative dentistry and the 6-lesson approach. And if we're doing the 3rd day, it will be how to treat endodontically, how to restore endodontically treated tooth. It's a very interesting, heavy hands-on, a lot of theory, which is what I found with David Alleman. If there is something that I have to really praise and really appreciate from him, is that he made me read. Not just have someone that comes and this is good, like this is good. I show you my keynote about this first presentation, and it's heavily based on articles that are showing different things, and all of them will have a point. Why this? Why not this? And why do I think and why do I have this opinion? And I think this is one of the best things that you can have from Dr. Aleman and from Davey, because Sammy as well is for me one of the most amazing person. I would like you to have a conversation about whatever you want, because if
he's been invited. He's just got to click on the link and then book in, my friend. He's more welcome to join us to geek out on biometric dentistry. It's a topic that I think is really exciting nowadays. It's been around for a long time. We've known about it. For me, it's adhesive dentistry on steroids, right? it's like that.
I agree. I do love biomimetics, and I know where that, but I like more my adhesive and restorative dentistry with a lot of background on biomimetics. I think it's just I understand what you're saying exactly. Is a perfect wording. It's a big, intense thing, but I think what really kind of like enlightens it is the amount of literature that really provides to dentistry and for clinicians to learn.
And I think what it is provided, based on speaking to my biometric colleagues, is guidelines and protocols, decision-making skills based on sound literature. That's what I've interpreted so far, basically. So I think that's great. I want you to tell the website and also how we can follow you on Instagram.
So my Instagram is it's a funny one, is German Tekilla. So it's German tequila. It's nothing to do with tequila, even if people think that it's something to that. It's just a funny thing that came from university. Mantequilla in Spanish means butter. So I play with my name just like to do that when I was at university. So it's German Tekilla. And then we can have a look at getbonded@taybonded.co.uk, and you will find all the information about that course in the UK. If you want to level up a little bit more and have a 1-year program, I will recommend you to have a look to Mimetica. It's another great program that I recommend. Have a look to Raphael Wyman, Hugh Byrne, and Philip Kulemans. Amazing clinicians, researchers that also I'm collaborating with them, and I'm going to be in May. I'm going to be lucky to be with Junji Tagami. I'm going to be lucky to be with Alisada around. These people teaching all of us is an amazing program. It's David Jardol, which I think you've met before. Another great clinician. So it's if you are interested in doing something a little bit more a long year course, it's another great option. And if you also want to have a look, check Emulate is another restorative course based on biomimetics and incredible hands-on with two amazing people like Fran and Stu, Franz Belford and Stu Beggs. Incredible hands, incredible talent.
And we have to shout out to Taylor Patton again, the hybrid layer, as a good resource to read up and it's an introduction to biometric dentistry. I love what he's done there. So there's plenty of learning to be done there. Yeah, thanks so much, my friend, for giving your time up.
Thank you. Can't thank you enough, honestly.
Thank you, buddy. Well, there we have it, guys. Thank you so much for listening and watching all the way to the end. Hope you enjoyed learning about Caries Detector Dye, and maybe you may start implementing this in your practice and you'll be able to use it properly from the get-go and interpret the data so you can get the best bond strengths possible. Now that you've listened all the way to the end, do answer a few questions, get that CPD that you well and truly deserve. By the end of the year, all those hours will rack up. And if you want to refer to some of the notes, you can always download that as a PDF as well by scrolling on the app. And of course, if you enjoyed this episode, do consider leaving a review or a rating, depending on which platform you're listening or watching on. It really helps a lot. Thank you so much, and I'll catch you in the next one.